Hi ladies and gentlemen, welcome back to BGS Clinics. In this video, I will begin with how to perform general examination. Basically, what is the role of general examination in clinical assessment? Unfortunately, general examination is often performed casually as a formality without serving the real purpose. Actually, it is so important that it is always conducted as the first part of physical examination, irrespective of the problem with which a patient presents. In the third video on this topic, I will discuss how to draw a clear-cut 4-point conclusion at the end of general examination, which has a significant bearing on the treatment. There is one more point which I would like to discuss at the outset, and that is about the sequence in which general examination is conducted. As a student, you may follow the system which your teachers or the examination board demands. That's fine. The sequence that I have adopted here is slightly different from the one that is traditionally followed. Mind you, only slightly different. So, it does cover all the points that are being taught for generations, but I have tried to make it more practical. It is time tested as I have been practicing it for years. So let's begin. These all are the points which should be examined while conducting general examination. Is the patient conscious, cooperative, and well oriented in time, place, and person? How is the gait? Does the patient seem to have adopted any specifically preferred posture? Is the patient generally active or otherwise? Are there any signs of distress? Does the breath or body have any peculiar odor? Then examine the eyes and face. Note if there is any specific facial expression. Examine the lips, tongue, neck, skin. Examine the hands and lower limbs. Then check vital parameters and jugular venous pressure. Measure the height, weight, and calculate body mass index. Judge the performance status. And at the end, draw the conclusion. When do you say that a person is conscious? A person who is awake and alert is said to be conscious. If not, then what will you do? Shake the patient gently as if trying to awaken a person from sleep and speak in loud voice. If the patient opens eyes, responds to questions, and falls asleep again, then the patient is said to be drowsy or lethargic. If drowsiness is prolonged, then it is a bad sign. Persistent drowsiness suggests a pathology in the central nervous system, including head injury, effect of a sedative, fluid electrolyte imbalance, and any serious life-threatening disorder. If the patient does not respond to verbal instructions, then apply painful stimuli by rubbing the sternum with the back of your interphalangeal joints or pressing on the eponychium with the edge of your fingernail and see how the patient responds. The patient may open eyes and lapse into an unresponsive state after the painful stimulus ceases. Verbal response may be slow or even absent, and motor response either normal avoidant or stereotypic. These are the stereotypic responses. This is abnormal flexor response, and this is abnormal extensor response. Such a deteriorated level of consciousness is called stupor. If the patient remains unarousable even after application of maximally painful stimuli repeatedly, then the patient is said to be unconscious. Stupor and unconsciousness suggest a potentially life-threatening problem affecting the two hemispheres of the brain, brainstem, or both. During the basic neurological assessment of patient, the ABPU scale is widely used. This is a very simple scale which will give you an idea about the status of the central nervous system, enabling to take a judgment about possible need to protect the airway. This is how it goes. A means alert, the patient is conscious. V means the patient responds to verbal commands. P means the patient responds to only painful stimuli. And U means the patient is unresponsive. So, these are the successively deteriorating levels of consciousness: drowsiness, stupor, and unconsciousness. A drowsy patient responds to verbal commands. A stuporous patient responds to only painful stimuli. And an unconscious patient does not respond to even painful stimuli applied repeatedly. The usual sequence of history taking and physical examination does not apply to this situation. An unconscious patient will soon become hypoxic. You first need to protect the airway of such a patient. A stuporous patient has to be monitored very closely. You may have to take a control of the airway any moment. Is that clear? Alright. In practical Viva exam, you may be asked a question: how will you manage an acutely unconscious patient? So prepare and be ready to answer this question. Now we proceed with examination of the patient who is conscious. Note how was the gait as the patient entered the examination room. Was it normal or otherwise? Various neurological, neuromuscular, or musculoskeletal disorders may lead the patients to attain various kinds of gait. For example, spastic hemiparesis, Parkinsonism, etc. This gait is attained in a very common acute surgical condition. What are your observations here? The patient seems to be very cautious while moving, preferring to stoop forward, and is protecting the painful region of abdomen with clasped hands. He is looking in distress too due to pain. This typical gait is called appendix shuffle, so called as it is classically seen in acute appendicitis. Then see if the patient seems to have adopted a specifically preferred posture. An acutely ill patient lying supine quietly without making any unnecessary movements is likely to be suffering from acute peritonitis. A patient who is restless, tossing or rolling about in bed in agony, unable to find a comfortable position, suggests a colic. A fixed flexion deformity at the hip joint suggests iliopsoas abscess or hematoma. Patients with cardiorespiratory embarrassment or pancreatic disorder find themselves more comfortable in sitting up position. Thus, a specific posture adopted by the patient may give a clue to possible diagnosis. This is a video which I will play soon. A scar visible in right lower quadrant of abdomen is a scar of appendicectomy done in the past, but that had nothing to do with the present problem. Anyway, once the video begins, note how the patient is lying quietly without making any unnecessary movements. Note the amplitude of anterior abdominal wall movements which normally occur with respiratory excursions. It is minimal in this case. The anterior abdominal wall is practically splinted. As a result, respiration has become rapid and shallow as a compensatory mechanism. Okay? Now watch the video carefully. So which diagnosis is suggested here? Acute peritonitis. This patient is restless, tossing and rolling about in bed in agony, unable to find a comfortable position. Typically seen in ureteric colic, most commonly caused by a stone obstructing the ureter. Does the patient appear to be active or otherwise? Patients with anxiety, thyrotoxicosis appear restless. Or does the patient appear quiet and slow to respond? Possible causes are depression, hypothyroidism, or the presence of any significant illness. Does the patient appear in distress? What are the clinical features of distress due to pain? Well, the patient will show wincing, and the patient will be constantly seen in an attitude of protecting the painful area. Anxious face with fidgety movements. Fidgety means anxious, restless, inexpressive or flat affect, poor eye contact, and psychomotor slowing suggest anxiety or depression. Labored breathing, wheezing, and cough suggest respiratory distress. Face is the mirror of one's pathological and emotional status. Staring look due to retraction of upper eyelid and expression of fear due to exophthalmos is seen in hyperthyroidism, specifically due to Graves' disease. Sunken eyes, drooping eyelids are seen in the terminal phase of illness prior to death. Pale puffy face is seen in nephrotic syndrome. Edema usually appears first around the eyes in the morning. If edema is severe, eyes appear slit-like. Flat or sad expression suggests depression. Then examine the lips and tongue to look for hypoxia, anemia, state of hydration, and nutrition. Bluish discoloration, meaning cyanosis, suggests hypoxia. Pallor is due to anemia. Dryness is due to dehydration. Tongue looks red due to glossitis, and it occurs due to vitamin B complex deficiency, which is usually coupled with undernutrition. So that's it in this session. We'll continue general examination in the next video.